Rod, thanks so much to you and to all of Seattle Science Foundation, Linda, and to Juan for having me here. It's a pleasure. As you said, Rod and I we go way back, about 20 years now, since the beginning of when we started seeing Luis doing what he was doing. So the cool thing about this is I think everyone on this panel, we've been some of the earliest adopters of the procedure, of the lateral access portal or channel. So we all have great experience with it. And the cool thing is we're now at a point where I can kind of talk about the traditional approach, right? The Transpsoas approach, that is the traditional approach of lateral access or of the contemporary lateral access surgery. So very cool in that regard. It just shows how far we've come. Given the majority of the panelists, or not panelists, but the attendees typically have a pretty good experience performing lateral, and they're looking, again, this is more an advanced techniques. I've kind of thrown out all the technique slides, and I think Neil did a great job starting us off describing the technique, and quite honestly, it's very similar with the exception of going in front of the psoas, you go through it. And I'm going to talk about a little bit about the, Rod asked me to speak about the anatomy and the complications as well. So clinical indications, I mean, anytime you need to get to the disc space, right, you can do so laterally. And truly with degenerative disc disease, with instability, recurrent herniation, stenosis, degen, spondies, low-grade spondy, pseudoarthrosis, discitis, scoli, trauma, arthroplasty, revision. These are all appropriate clinical indications. And what I want to be clear here about is that what I am not debating with anyone. I don't think anyone on this panel is going to debate that we have the better approach, that pre-psoas is better than trans-psoas, this is better than the lateral ALIF or a prone lateral. The bottom line is that if you have all these tools in your belt, you can decide what's best for that patient on that particular day with their unique anatomy. And that's the important thing to take away from here, is that these are all tools, and put them all in your belt. It's also important to, of course, understand the limitations, the anatomic limitations, such as significant scoliotic rotational deformities, or if there's elevated crest or an elevated psoas sign, therefore pulling the nerves with it. Retroperitoneal scarring can stick the vascular structures down. You may want to avoid, in that case, high-grade spondies where the nerve is elevated, difficult to find that lateral center. These are some limitations that prevent us from getting there. But let's speak a little bit about the anatomy. Everybody's seen these slides, right? We know that as we work through the psoas muscle is very different when you're rostral versus when you're caudal in the spine, compared to not only its bulk, but the location of the structures within and around. So the vasculature becomes more close in proximity. The nerves themselves can become more anterior, which we'll talk more about. But you gotta understand the anatomy and look at your imaging very closely. So here's a nice Netter shot showing, you can see the sympathetic chain. And that's one thing that I think would be great to get more from Neil, is the patients that I've seen end up with sympathetic trunk injuries are those that do have more anterior, the grafts are placed more anterior, or the approach was more anterior. So something that would be interesting to get his perspective from. It's not a common complaint, but I think everybody has those patients that come back and say, my foot one feels colder, one feels warm all the time. Or they complain of swelling, and sometimes we kind of blow that off, but perhaps that is actually an underlying sympathetic injury, something to be aware of. You can see where the sympathetic trunk lies more anterior on the vertebral body. And if we can actually pull out that psoas muscle and kind of look more in transection, you can see the general femoral nerve typically pops out around L3-4, and then continuing on within the bulk of the psoas major are the femoral and the obturator nerves. But prior to at around L4-5, the lateral femoral cutaneous, actually it's a little lower, LFCN pops out. So sometimes we see patients come back and they're complaining more, of sensory dysfunction in that region. But I think two others that we often pay minimal attention to is the iliohypogastric and the ilioinguinal. And what Neil showed is a nice visual dissection, but not everyone, including myself, performs that type of dissection. We do a little bit less, smaller incisions, and do things a little bit more blindly sometimes. And therefore you have to be aware, especially when you're throwing your finger in there and trying to create that space in the retroperitoneum, not to avulse these, or injuries and stretch these nerves, because there are consequences to doing so. Here's another, just a different viewpoint showing where the nerves themselves continue to traverse within, and then as they exit the psoas muscle, you can see the LFCN exiting early, followed by the general femoral nerve coming out at 3-4, and then the femoral and again obturator continuing on in the bulk of the psoas muscle itself. Repetition is never bad. Just again showing the iliohypogastric and the ilioinguinal as they extend out and traverse through the oblique musculature. Again, making note that as you're working through those muscles, you want to be aware of those. And I got is Alp Ospinar. Alp is one of our residents. Wanted to label out these as we look at them. So the iliohypogastric and the ilioinguinal, right? These have projections off of L1. General femoral as L1-2. Femoral nerve itself is 2-4, as is the obturator, and then lateral femoral cutaneous is at 3-4. Right? These are the distributions. So important. We'll keep talking about these, but this is one of the reasons monitoring has become so important as this procedure has evolved. Remember, lateral access surgery has been around for a heck of a lot longer than 20 years. It was just often abandoned because of the types of injuries and complications that were occurring. And I feel like when this all came about 20 years ago, it's because of, and became much safer in contemporary practice, it's because of the addition of the monitoring. And there have been numerous publications describing where the projections of these nerves and how to make it safer. Here's Alan Levy's group back in this is over 10 years ago, when they described as you move from rostral to caudal, that the lumbar plexus moves from posterior to anterior. And this is, of course, why we have more and more difficulty as we traverse from rostral to caudal performing the procedure and minimizing the nerve stretch and the nerve injury at that lower levels. And of course, now there's the nerve localization with the probes. This is something that is routinely performed. And there are article after article after article of new incorporated evoked potential papers that are suggesting that the spontaneous as well as triggered EMGs, you got to remember, these are not tests of neural integrity. These don't prevent injury. What they do is help us localize. But the primary mechanism of injury, oftentimes with lateral access, is stretch retraction and focal ischemia on these nerves. So it's important as we work through, we know what the safe zones are and we continue to stay within them. However, it's also important that as our neuromonitoring specialists continue to contribute, that they help come up with things that we can add to our EMGs. For example, transcranial MEPs have become particularly helpful. And when we put these together, we get more and more information, and we're less likely to have some of these nerve complications as we're working through the psoas muscle. Several papers have put out, this was Fessler and Liu, that they talked about the hip flexor weakness. And we want to talk about that. We want to have the same language too. There's a big difference between nerve injury and psoas injury or trauma or inflammation, which is what they were contributing 25% of their patients waking up having these issues with. And as they worked their way down, as the psoas muscle became bulkier, they were noticing, of course, greater incidence of hip flexor weakness attributable to that psoas. This is very different than, of course, talking about nerve injuries themselves. And this is a paper where they looked at nerve injuries. But it's interesting, again, if you look at, say, for example, Isaac's paper, they report 33% of their patients had nerve injuries, whereas someone like Rogers looked at 600 patients and has less than 1%, or Jim Yusuf around 1%, because we weren't talking the same language at that point. We were saying these are motor deficits, but it's actually motor was not just equal to muscle. And we got to remember that there's a big difference. Nerve injury is a very different injury than psoas injury, and it has a completely different recovery as well. Uribe has helped us by numerous studies. This is one of his original cadaveric studies where he looked at the cadavers and helped us determine the safe zones. Again, pointing out that in zones 1 and 2, you're more likely to come across the genitofemoral nerve. You're more likely to have issues with the femoral nerve down at L4-5. And bottom line is to have a clear understanding of what the safe zones are, have a clear understanding of the anatomy, be able to visualize your pre-op imaging and incorporate that information such that before you get to the operating room, you have an understanding of where these structures are. This was, again, Mike Wang and Levy, who talked about injury to the femoral nerve, which this is exceedingly rare. It occurs in typically less than 1% of patients, but it is catastrophic, right? It severely affects the patients. They get severe atrophy. There can be dramatic aesthetic issues, but they have difficulty with walking, simple ambulation. That's a major problem. But there's also nerve injuries that don't appear so catastrophic to us as surgeons, but to the patients they can be. And one was, which was noted here, in occurring in greater than 4% of patients, is that abdominal flank bulge. And this is related to denervation of the abdominal musculature, secondary to stretch of those two nerves that are popping off at L1-2, the iliohypogastric and the ilioinguinal. And you can see here thinning of the abdominal wall musculature, which is of course distinctly different from incisional hernias, which can occur when there's actual, the contents of the peritoneum are actually traversing through the incision itself, right, or through the injury of the abdominal wall musculature. That requires surgical repair. That requires a general surgeon to go in and place mesh and close that hernia. That's distinctly different from the abdominal wall paresis that occurs from stretch or injury to the nerves that are innervating the abdominal wall musculature. But it says 4%. I say I see at least one of these a year. At least once a year, I have patients come back and they say that their abdomen on the ipsilateral side to where the incision was, they've noticed a bulge, they've noticed, and I always get nervous, of course, that that's a true hernia, but the majority of the time it is not. It is a pseudo hernia. And interestingly enough, these do resolve almost always on their own. That was a study by Uribe showing that the patients had all, except for one that they had lost to follow-up, had a complete resolution of their symptoms without any surgical intervention. But again, important as you're performing that blunt dissection into the retroperitoneal space to be careful of those more superficial nerves traversing through your oblique musculature. So complications, right? There's a variety of complications, and these aren't particular to just the transpsoas. This can occur with pre-psoas. It can occur with any time you're entering the inner body space through the lateral corridor. But there's ALL disruption, implant malposition, psoas hematomas, the vascular and neural injuries, subsidence, fractures, and then of course the typical paresthesias and palsies. So some tips. Very, very important is understanding patient selection before you even get to the operating room. I always say this to the residents: is the majority of the complications can be avoided by having a clear understanding of the anatomy and of the plan and what to expect. So understanding the pathology, understanding the limitations, the surgical limitations, the surgeon limitations, understanding when we look at this picture here, we're looking at 4-5. Can you get to 4-5? Certainly not from the left based on that coronal angulation. However, what about from the right side? Well, as Neil showed, we do have multiple options. You can get there. We do have tools. We do have angled instruments, and we have the ability now to be able to get there. And oftentimes, sometimes manipulation of the anatomy itself, pulling the iliac crest back a little bit and taking more of an anterior approach, yet still traversing through the psoas muscle or going pre-psoas. Another is that elevated psoas sign. You got to be careful because sometimes, especially if you have a sacralized lumbar spine, a L4-5 can actually be a lot more anatomically like L5-S1. And you probably all heard the excited Dumbo, right? There's the Dumbo when the ears are up, when the psoas is elevated above the anterior aspect of the vertebral body. You got to be careful there because the nerves are stretched with it. And when you're in the psoas muscle performing a transpsoas approach, those nerves are more likely going to be in the way. This is what you're looking for. You're looking for the chill Dumbo, right? Where the ears are either below or at the superior aspect or the anterior aspect of the body. Again, patient selection with spondylolistheses. Are these mobile? Are they immobile? Do you need supplemental fixation? I'll show two quick examples of similar cases. This is a patient that she's got pathology throughout her spine, but at 4-5, she had a pure L5 redic. You can see there's not significant motion on flexion extension. And we went and did a single level standalone lateral, and she had dramatic resolution. And by a year out, we get CT on everyone a year out. We can see this very mild subsidence, still good at indirect decompression of that space, and she remains with full strength. However, this is another patient that had similar pathology, 4-5 pathology, but you can see there's with as soon as she's upright and with flexion extension, there's greater translational motion. occurring at 4 or 5. And this is another patient I attempted to do a standalone. This is very early on. This is back from 2009. But 2 weeks after the surgery, she had done quite well in the first 2 weeks, but as she became more active, you can see that translational motion was not supported from the back, and she ended up with a vertebral split fracture that ultimately ended up with a lot. The attempt to do less ended up being a lot more, and she ended up with a L4 to S1 fusion. So understanding that and just understanding the pathology itself, patients that have collapsed disc spaces with anterior kinking of the ligament, those patients are going to do better than patients that have significant posterior ligamentum flavum hypertrophy and calcification and facet arthropathy, right? Those are patients that aren't going to do well with indirect decompression and ligament ataxy. So understanding the pathology, again, arthritic joints, reduced. Are these patients rigid? It's very difficult to open up patients that have severely arthros joints. Sometimes you got to improve their flexibility with posterior osteotomies before you can get that stretch and indirect decompression. Looking at their bone quality, osteoporosis, we found that patients that have T-scores of less than -1, much higher risk of them subsiding and necessitating a secondary surgery. So these patients need to be backed up from the start. Similarly, with the number of levels fused, the more levels you're performing, the more likely you're going to need to back these up. The more rigidity you're going to get, and the more likely doing so from the back is going to be beneficial. So I'm not going to get into scoliosis much, because I know we've got a lecture from Neil shortly, but there's lots and lots to think about before you get to the operating room to determine how successful you'll be with your lateral procedure. Is it fixed? Is it flexible? What's the SBA, the mismatch? How much rotational deformity is there? You're going to work in the concavity or the convexity. A couple quick images just to show. You can see the pre and post. These are patients that had anterior column resections at one level with laterals above and below, and you can see the dramatic restoration. There's not a single screw, not a single posterior screw in this patient. You can see dramatic improvement. And here's another example, again, showing a patient that had previous surgery from 4 to 1 with an ACR right above that. You can see pretty dramatic. And then when the screws go in to stabilize it, we have very strong procedure here. So lastly, I'll just finish off with some tips when working through the Transpsoas, or again, working through any of these approaches, but performing a lateral interbody fusion. Study the adjacent normal levels, understand what your goals are, be cognizant of oversizing the graft. Over distraction leads to subsidence, and that occurs in the operating room to start for the most part. If it happens in the OR, it's going to happen post-op, and you're going to lose the benefits of that surgery. You can see some end plate violation there, and then within 6 months, it actually was within 6 weeks, but here it really shows at 6 months, complete loss of the benefit of that surgery. Avoid overbreaking the table. There's data to support that if you take 20-year-old college students and you lay them on a table in the lateral position, tape them down that way for an hour, that half of them, if not more, are going to wake up with nerve palsies. Again, this isn't something that's long-term, but that stretch across that nerve, across that muscle, and the space in between can be significant to patients, even with normal, healthy spines. Be careful. Every image that you take gives you information. You can see here the Scoville retractor, and you can be careful as you're putting in your tools that they can move what's right in front of that, your iliacs or your IVC or your aorta. So be very careful and cognizant, and use every single image as an opportunity for information. When you're performing up against the lateral spine and you're putting in grafts, there's a tendency, especially as you put your graft or your trials in, for the retractor to move away. And remember, that retractor is keeping, when you're in the Transpsoas, when you're performing the Transpsoas approach, the nerves, the muscles, the retroperitoneal contents, peritoneal contents, these are all close by. So as that retractor backs up, you can get into danger. And I think that's going to be even more important as Dr. Uribe is going to be showing us the single position prone lateral. When you're performing the procedure, make sure that your retractor is against your osteophytes and that it stays against your osteophytes. Sometimes apply that downward pressure. So important tip there. Also, don't overexpand your retractors themselves. What's sitting right in front of that retractor, if you mal it up against it, your segmental artery, you can end up with a significant vascular injury. So the majority of complication avoidance occurs prior to even starting the operation, prior to your skin incision. Have a very important patient selection, review your imaging ad nauseum, position your patients absolutely perfectly and properly, moving the patient with each level, understanding your neuromonitoring as well as its limitations, and of course, much better to avoid than to manage complications. So the Transpsoas approach, it's a safe, effective, less invasive surgery to treat a variety of lumbar pathologies, but extensive experience continues to allow us to hone in our skills and continues to evolve the procedure. And with continued evolution and continued access portals, whether it be through the psoas or in front of it, someday potentially behind it, who knows where we're going next, but the evolution continues. Thanks very much.
Yeah. Thanks very much, Adam. You look good. So, Adam, just to close, so we keep on time. You've been one of the leads of the Transpsoas approach, I would say, on the world, and many people have been following you. So, just to round this, first, you can tell the audience in one sentence, first, why you didn't migrate to pre-psoas and any variants, and second, what is your biggest, most important recommendation to a person that is studying lateral Transpsoas and he wants to have a really good outcomes?
Yeah, you know what, Juan, this is one of those things that I think what we do see sometimes folks migrating from Transpsoas to pre-psoas. It's rare that we see folks migrate the other direction. And I think, Neil, you started Transpsoas, correct? Yeah, so Neil was one of those that decided to go anteriorly. And initially, I did do a few of them. I think I got a little bit nervous as I was starting to see some of the structures that scare me. When I was going pre-psoas, I would see some of the vascular structures, and I don't want to see them. I want to stay away from them. I want to stay behind them. And I got very good at performing, the Transpsoas traditional lateral interbody fusion. And it's something that I've stuck with because we have very good results. And what I found is that the greatest likelihood of there being a complication is how long it takes you to get in and out. And we've gotten very fast and adept at getting in and out. And that's what I would say to answer your second question, instructing folks that want to start out is do these in the lab. Do tons of these in the lab. Do 50 of them in the lab. Take 4 or 5 cadavers. Go to these courses that are offered from all these great companies that are supporting us, and do a ton of these operations. So it's almost like muscle memory performing the operation, and you can get in and out doing these operations very, very quickly. And that what we found is kind of the number that we've, I think, adopted across the group is about 20 minutes. If you can get in and out, the likelihood that you're going to have any lasting neurologic deficit is exceedingly low. Very interestingly, sometimes we'll come across a very tough case and, it'll take 30 or 35 minutes and we don't have, any neurologic compromise post-op or any even hip flexor weakness. But then we do a case in, 15 minutes. And unfortunately you do. I had a patient that we did a very, very expeditious operation, and the guy was a hockey player, actually an elite hockey player, and he had a huge psoas, and there was not an indication from monitoring at all. We did the Transpsoas approach, got the graft and everything looked beautiful, and he woke up and had significant hip flexor and extension. So he had a femoral nerve palsy that I just can't tell you why it happened. We didn't have any indicators from monitoring. We didn't have any indication from the length of the surgery or any problems at all. But I was attributing it to the fact that he had such a massive psoas muscle itself that the bulk of the psoas, muscle was what was compressing the lesion, or I'm sorry, the nerve. So, we can't predict everything. I think we're getting better and better at it. I think time is of the essence in this procedure. But I'm adept. I'm very good at performing it, at teaching it through the psoas. In situations where we need to be more anterior, I'm capable of doing it. But if we got apples to apples, I would choose Transpsoas. But it doesn't necessarily mean it's better. It's what I'm good at.
Yeah, and that's a great answer, Adam. So the first thing for the audience is one is not better than the other one. You saw Neil show very great how you can go pre-psoas. I would say, just complementing your answer is, create your own system get, as you mentioned, muscle memory, and make sure that you master your moves. And then I bet you your outcomes are going to be amazing. So what you don't want is to, change, like you're a golfer, change your swing every time you're gonna hit the ball and following million theories that you listen from the pros. You get your own swing, mastering, and I bet that you're gonna play and perform very good. So thank you. It was an amazing presentation. Now we're gonna go in the next one, and I want Rod to introduce, actually Luis Pimenta will introduce our next rock star from Brazil.
Actually, hey, Adam, great talk. It is interesting. May I ask a question instead of a comment? It's a question to you, Adam. We have around 20 years of doing laterals, right? With all these huge success. I want to have your opinion why, after all this year, after showing day after day the rate of success that we have, why only 20% of the spine community adopts lateral? What's the point that, in your opinion, makes 80% of spine surgeons not really interested in learning that?
Yeah, you know what? I don't think, well, if you look at that number, so we've got 20% of spine surgeons performing lateral now. Think of what that number was 5 years ago, 10 years ago. I think it's definitely changing. And I think as our programs, the residents and fellows are coming out with experience, they're more adept at performing the procedure, and they're more likely to incorporate it into their own practices. So I think a lot of it simply has to do with, it's not these kind of revolutionaries. It's not people like yourself that are saying, hey, trying to convince people anymore. We're now talking about traditional, lateral lumbar interbody fusion, because it's been around for 2 decades. It's now an accepted part of our practices. When we look at the ISSG and all the data that's out there, we compare open to MIS, it is because of lateral. It is lateral that has created this entire subgroup of surgeons that are now performing deformity surgery because of lateral. So I think it's really a part of familiarity, and now they're becoming much more familiar. I think 5 years from now, we're going to be looking at 30%, and 10 years from now, we'll be looking at 50% that have it as part of their tool belt. But a lot of it has to do with comfort. And one thing that's evolving with the procedure is the positioning. And folks are not particularly comfortable performing lateral procedures, lateral surgery. And with the addition of prone, now, I mean, even the residents that haven't had lateral incorporated into their training are going to start feeling more comfortable of, the prone position, I'm very familiar with that. So now this is a different approach. And I think that's going to continue to add to the number of folks that are interested and comfortable incorporating this into their practice, is because they're going to be doing it in a position that they're more comfortable with and not having to, rotate patients as much. So I truly believe it's comfort. I think initially it was people were afraid of the complications, but I think we're showing that, lateral access surgery, the complication rate is no higher than that of any other approach in spine. In fact, from many, it is lower. So I think with comfort and time, we're going to see more and more folks adopting, as we already have.